Thank you, Bob, for outstanding talk. And now, next couple of hours are mine. So we have been going in a sequence, and so now revascularization in chronic stable coronary disease, going beyond FFR. So we all know that we are all kind of guided by the FFR now, that we have to demonstrate the functional significance of the ischemic lesion. So there are no disclosures for me. So we all know that coronary artery disease is bad, and it is bad because it causes heart events. And as we all know that the progressive atheroma that leads to significant stenosis, and when there is stenosis, it reduces flow. So there is ischemia, and then ischemia causes events. And that is kind of a dogma. And what is a dogma? Dogma is statement of ideas accepted uncritically or the rules that cannot be questioned. And that is something which has etched in our minds for decades now, that whenever there is a stenosis, there is ischemia, and whenever there is an ischemia, there is a heart event. So the approach is obvious, that we have to find coronary stenosis because it causes ischemia. We have to find ischemia because it causes events, and then treat the stenosis because it will reduce ischemia, and it should improve outcomes because we have fixed the stenosis, we have reduced the ischemia, and it would automatically mean less myocardial infarctions and less deaths. So where has this dogma come from? So this dogma started with some excellent studies which were in late 1980s, mega surgical trials, randomized trials, where we had subjected the patients with more than 70% coronary artery lesions to either surgical revascularization and compared them to the then optimal medical therapy. Now, the results were very uniform. We saw that the survival was much superior in the subjects which were surgically revascularized. There was a significantly improved freedom from angina, and also the exercise capacity was significantly improved. But where did this 70% come from? 70% came from the canine experiments, where we had all normal arteries and we created one lesion in one artery, which was, once it reached the 70%, there was a significant decrease in the coronary flow reserve. And we thought that that is the point that we really need to take care of. But the question that we need to ask is that, were the lesions same in 1970s and 1980s the way we see them today in presence of statins and other lipid lowering agents? And did we have enough of the medical therapy at that time, and can we call it optimal medical therapy for today? And indeed, if we look at the pathological studies that were available, and some of the finest studies that came from Dr. Michael Davies from England, that demonstrated the pathology from those times, and you will see whether those plaques were high-risk plaques where they have ruptured, and here you will see that there's a huge necrotic core here, large lipid collection, and even if there was a stable plaque, here you will see that there is a significantly thick fibrous cap here, and it's a stable lesion, but it is full of lipids. So these were lipid-rich lesions of those times. So it required more trials. And here came some of the transformational trials, quite like the Courage trial. And actually it needed a Courage, that we needed to compare the optimal medical therapy again with the PCI plus optimal medical therapy. And the result was that at the end of 5 years, there was no difference whether we treat these subjects with the optimal medical therapy or we revascularize them. And it indeed brought down the trends of the revascularization in the country and worldwide. But was that right? Should we continue to do that? And at that time, there was another group of studies which came up. These were the FAME family of studies. And specifically, when you look at the FAME2 study, where you compared the subjects who had abnormal FFR, you subjected them to optimal medical therapy or revascularization, you found that there was a significant difference in outcomes. and that the ones which were subjected to revascularization did much better as compared to those who were on optimal medical therapy. But here we need to compare what our primary endpoints were. The primary endpoint in the Courage trial was survival free of death or myocardial infarction, while the primary endpoint in the FAME2 trial was the cumulative incidence of death, myocardial infarction, or need for urgent revascularization. And if you really look at this FAME2 trial, you'll find that the results actually represented the need for revascularization rather than death and MI. So, if you look at death and MI, there was no difference in the death and MI by revascularization, and it was essentially the need for revascularization or need for urgent revascularization that was changed by the interventional therapy or invasive therapy. So then the question comes up that what happened in Courage? Why did Courage tell us that there was no difference? So if you reanalyze the Courage also, you'll find that yes, there was no difference in the survival free of death and myocardial infarction. But when you look at the need for urgent revascularization, you will see that the curves are exactly the same as we saw in the FAME group of studies, suggesting thereby that no, there is no difference in the death and myocardial infarction, but the need for revascularization would be more if you treated the patient with optimal medical therapy. And we thought that ischemia will give us some of the better answers because it was much larger number of subjects, followed longer, and done after we had accumulated significant amount of knowledge from Courage and FAME group of studies. What do we find here? Again, 4 to 5 years of follow-up, and you'll see that there is no difference in the invasive arm and conservative arm again. And then we were brought to the same level that is there a difference? And then when we look at the post hoc analysis of the ischemia trial, we find that indeed there was a significantly higher likelihood of having spontaneous myocardial infarction in the conservative arm. And if you will look at the spontaneous MI rate, the conservative arm, it was 5.8%, invasive arm was 2.8%, with an absolute risk reduction of 3% and relative risk reduction of more than 50%, suggesting thereby that indeed there was a difference in the conservative arm and the invasive arm. So the conclusion that did ischemia demonstrate failure of revascularization to reduce myocardial infarction? Or, as I put it, or is it a failure of ischemia testing to guide revascularization? So let us go back to the FAME2 data now. So we come to the FAME2 data and see the 5 years extended follow-up in this particular case. What do you find here? That yes, again at the 5 years, there is no difference in myocardial infarction and the death from any cause, but there is significantly higher need for revascularization in the conservative arm. But if you look at the end of 5 years, there are 50% of subjects who did not die, did not develop myocardial infarction, did not require revascularization, and had the same relief for angina as you would have in the optimal medical arm, in spite of the fact that they had abnormal FFR. So, not all subjects with the abnormal FFR need intervention, and we need to identify those subjects who indeed require intervention. And there was a very elegant post hoc analysis of the FAME2 study where Habib Samadi and colleagues from Emory, they looked at the subjects who had optimal medical therapy. They took their coronary angiograms, the regular coronary angiograms, did the 3D reconstruction of that and tried to identify the wall shear stress of the lesion that was considered to be the target lesion there, and found that those who had significantly high proximal wall shear stress, they did much worse as compared to those who had normal wall shear stress. And as a matter of fact, Those who had higher wall shear stress, it was much superior to the FFR abnormality in these cases, suggesting thereby that the plaque composition does make a difference, because the wall shear is telling you that there is a difference in the plaque composition. Or possibly these are the one which are lipid rich plaques. So can we really talk about the paradigms here, and would the paradigm be evolving here? What did we think? We thought any lesion and every lesion which is 70% stenotic must be sent for revascularization. And what do we think now? After the FAME2 group of studies, we see that there is a safe. It is safe to defer the FFR normal lesions, regardless of the degree of the luminal stenosis. But what can now we do? What we can do is that if there is a 66% of the lesions which have been left alone, and if we look at the Habib Samadi's study, and also look at the FAME2 study and see that 50% of those with abnormal FFR do not require, over the next 5 years, do not require the intervention. Can we take that bite away and only leave 33% of the lesions which truly would require intervention? And for that, we would need to identify the plaques which have a different composition from those what we feel as the stable plaques. So what are those plaques that matter? And here is the data from 300 subjects who had died, and we look at their plaques because of which the acute coronary events had occurred. So here we will look at stable plaque, which is in green color. Blue color is the vulnerable plaques, and the red color are the plaques which have already ruptured. And the one factor which identifies the most important determinant of the plaque vulnerability to the plaque rupture is the fibrous cap thickness of the plaque. So if you have a very thin fibrous cap, that is likely to result in an acute event. And we now know that if it is less than 85 micron, the plaque is vulnerable. And if it is less than 55, mostly these plaques have already ruptured if the lumen was stenotic enough in these cases. But how can you identify the fibrous cap thickness in a living human being? The only way that you can do it is by optical coherence tomography, which has a resolution of 10 to 15 microns. And obviously, you cannot take every patient to the cath table and do the optical coherence tomography. So what we did was that we did the analysis all over again and removed the availability of fibrous cap thickness as the available feature to us. And what you find now is that there are two important features here. One is the extent of the lipid-rich core, and secondly, the amount of or extent of inflammation in these plaques. Now, can we identify them by the non-invasive imaging? So these are some of our very early studies that we started to identify the fibrous the fibrous or the lipid-rich plaques by looking at the CT angiography, and we compare them with the intravascular ultrasound and demonstrated that we can identify the lipid-rich plaques by looking at their attenuation on the CT angiography. And whenever the plaques are low attenuation plaques, that is, their density is 30 to 50, less than 30 Hounsfield units, then these plaques are likely to carry the lipid-rich cores. So we thought that we could apply it to the data in the subjects who are presenting with the acute events. So here you would see that here is a subject with unstable angina, 57 years old male, comes with unstable angina, and we did the CT angiogram in him, and you can very clearly see that there is a positive remodeling, significant amount of remodeling here, and shown by the yellow colors. And you will also see that there is a very large low attenuation plaque, which is low Hounsfield unit densities here, much less than 30 Hounsfield units, shown by the red color. So large necrotic cores and positive remodeling, these were the two features that identify the plaques which were vulnerable to rupture, as compared to those which were two feature negative plaques. These were the stable plaques, you will see that there is no positive remodeling, there is no low attenuation plaque, but the lumen is critically narrowed. So this is a stable plaque. And then we also took it for the prospective study here. So 1,000 subjects with minimum of 2 years follow-up here. And as you can see in one of these plaques here, when you will see it in the higher magnification here, it's significantly positively remodeled, and you can see that there's a large low attenuation plaque here, again being a two-feature positive plaque. And one thing I would like to bring to your notice, that this is just proximal to the first septal branch here. So when this patient was followed up 6 months later, this patient comes back with acute myocardial infarction. You'll see that this is the first septal branch here, and the lesion is just before the first septal branch, suggesting thereby that this was the lesion that was indeed responsible for the future event. So when we looked at them, those lesions which had greater necrotic core and greater positive remodeling, they had earlier events and they had higher likelihood of having an event. And when we compared the two feature positive plaques with the two feature negative plaques, you can see that there was 45 times higher likelihood of having an event over the next 2 years. So a significant discrimination in the two. We carried the study forward, and with 3,000 subjects and 10 years follow-up here, and we thought that it will hold good. So we looked at the high-risk plaques. Yes, it is tenfold higher likelihood of having an event as compared to a non-high-risk plaque, but not as much as we had seen for 2 years. So here you would see that again, at 2 years with no high-risk plaque, there is no event as compared to significantly high events in high-risk plaque. But what happens in 10 years' time? Some of the non-high-risk plaques do indeed become high-risk plaques. And what we found was that the most important determinant of plaque vulnerability is plaque progression. And when we had the serial CT angiograms, and it was available to us in the 500 of these subjects, actually 450 of these subjects, we found that if there was a high-risk plaque and there was a plaque progression, there was 35 times higher likelihood of having an event when there was a high-risk plaque that did not show progression over the next 1 year, suggesting thereby that plaque progression is a prelude to the prospective or spontaneous myocardial infarction. Now, as the plaque progression is occurring, we also found that the plaque progression is associated with a decrease in FFR, regardless of the extent of luminal stenosis. And when we look at the FFR as identified by the invasive coronary angiograms and compare it to the CT plaque characteristics, you'll see that there are two determinants of the FFR. One is the quantitative coronary angiographic stenosis, and second is the amount or the extent of the low attenuation plaques. So the possibility is that even if the lumen is not stenotic, but if you have got a huge necrotic core sitting outside in the vessel and it expands the smooth muscle cells to the maximum, and you give them the vasodilators like adenosine or nitroglycerin, at that point in time, the area proximal to the lesion and distal to the lesion, that dilates well, leaving a necrotic core area as the bottleneck that cannot expand further, quite like proving what we had known about the Glagov's hypothesis, that only when the plaque area becomes more than 40 to 60% of the total vascular area, only then the luminal stenosis starts to occur. So looking at the similar phenomenon, it looks like that a simple necrotic core, even in the absence of critical luminal stenosis, can also lead to abnormal FFR and ischemia, giving us an opportunity that we would be able to intervene in these cases by lipid-lowering therapy. So in our study, which is coming next month in JACC imaging, you will see that we had these subjects who had their invasive coronary angiogram based decision about sending the patient to intervention or not. But we looked at their CT angiogram, if they had the CT angiogram, and these are about 750 subjects, and we looked at them and characterized their FFR by CT angiogram and characterized their plaque characteristics. So now we created the 2 by 2 tables here. Those who had abnormal FFR, as you can see here, and normal FFR, that is more than 0.8. HRP or the high risk plaque is present or high risk plaque is not present. And you will now get the 4 cells here. Those where FFR is abnormal and high risk plaque is there. These people did much better with the coronary revascularization as compared to the optimal medical therapy. On the other hand, if the FFR was normal, but high-risk plaque was there, as I had presented earlier, the coronary revascularization was still better than optimal medical therapy, but statistically not significantly, suggesting thereby that here we will be able to go with aggressive lipid lowering, and the possibility is that these plaques may be able to be squeezed by the medical therapy, because this is one of those situations where the Glagov's hypothesis is positive. The lumen is not much stenotic, FFR is normal, but you have got a huge necrotic core here. So it should be able to respond to an extreme lowering of the lipid status. Then if the high-risk plaque is not there, but FFR is abnormal, that is, this is truly a stenotic lesion, and this is a safe courage or ischemia population. These people, they do as well with optimal medical therapy as with the coronary revascularization, suggesting thereby that they may or may not require the intervention. And then finally, if the FFR is negative and HRP is negative, the optimal medical therapy did better than coronary revascularization, albeit statistically insignificantly. But obviously, it looks like that this is the cell which should be considered the inappropriate intervention cell. So if we come back to our same figure here, or the same pie diagram here, we'll see that we can take away a bite of those subjects who are FFR negative. But if they are FFR negative and HRP positive here, we obviously require a very significant lipid lowering in these cases. But from this high-risk plaque positive group, we should be able to squeeze a group out which does not have the high-risk plaques, and we should be able to leave them alone. And they would require intervention only if symptomatically these people are not comfortable with the optimal medical therapy. And all these CT angiographic features now can be identified by the artificial intelligence, and now more and more softwares are becoming available. Very recently, about 2 days ago, another software was approved by the FDA, which looks at both the FFR as well as the plaque characteristics, the heart flow algorithms. And finally, we now know the vessel lesions or the causes for the target vessel failure and target lesion failure, because once the intervention has occurred and these people develop the spontaneous MI over a period of time, these are obviously the new lesions, which are the lesions which are likely to result in an event specifically after the revascularization. So we should be able to identify by these automated algorithms which are the plaques which we need to take care of. So with a couple of slides, I will end. Here is a subject who had typical chest pain, positive stress test, CT angiogram was done, showed only 25% lesion in the mid-LAD. He's a 71 years old person. And when we do the FFR, you see that there is a significant FFR drop here from 0.89 to 0.76, just across that 25% lesion. And if you look at the plaque characteristics, you'll see that there is a huge necrotic core and significant positive remodeling. Lumen is only minimally affected here. We increase the rosuvastatin to 40 milligrams and added the ezetimibe in the patient. 6 months later, you'll see that positive remodeling has disappeared, necrotic core has disappeared, the lumen is the same, and when you look at the FFR, the FFR has normalized in this subject. And now we have many such cases where we can clearly demonstrate that in the absence of the stenosis with a large necrotic core, if the FFR was abnormal, you should be able to treat them with uh, lipid lowering. Now, there was a Prospect 2 study by Dr. Stone, which was presented about 2 years ago at TCT, and simultaneous publications in NEJM and JACC. You saw that their Prospect Absorb study, where they had normal FFR but large necrotic cores. So it is the other way around. Normal FFR, but large necrotic cores, and they had demonstrated that they can take care of it by giving the absorbable, resorbable stent in these cases. And although this was statistically not significant, possibly because of the smaller sample size, but we feel that probably these cases can be treated with lipid lowering, and only those cases may require intervention where you have high-risk plaques and the FFR positive plaques. And the last slide here, trying to tell you that as far as inflammation is concerned, I did talk about inflammation being the second important factor other than the necrotic core, and it definitely contributes to the plaque progression also, that now it has become possible that we will be able to identify the inflammation just by the same CT angiogram offline analysis of them, because the intra-plaque cytokine axis does affect the perivascular lipidity or the perivascular, the fluidity of the perivascular fat, and that it becomes less lipidic and more watery. If there is a cytokine axis, and this differentiation between the perivascular fat versus the epicardial fat, that could determine the presence of inflammation in the plaque. And this is the post-hoc analysis of the Scott Hart trial, where you can see that those plaques which had demonstrated the possibility of the plaque inflammation, they did much worse as compared to those where the plaque inflammation was not there. So to conclude, outcomes of the revascularization studies based on ischemia-producing coronary vascular lesions was observed to be superior to the extent of luminal stenosis, and that is the paradigm we follow today. However, at least a half of hemodynamically significant lesions fare as well with medical therapy as intervention, suggesting additional role played by plaque composition. Plaque composition characterized by CT angiography, verified low attenuation plaque, and positive remodeling best describe lesion vulnerability for major adverse cardiac events. Novel methods have suggested that the feasibility of detection of plaque inflammation by CTA as well. Prospective studies are needed to define the role of plaque composition in management of chronic coronary syndromes. And finally, our entire CT angiography imaging experience is based on binary presence or absence of the high-risk plaques, and machine learning-based strategies need be developed for quantitative plaque assessment at both lesion and vessel levels, which have indeed become available only about a week ago. Thank you very much.